this afternoon to have as our guest, Marisa Stahl, who is an assistant professor of pediatrics at the University of Colorado School of Medicine, where she does a lot of work with the Colorado Center for Celiac Disease. So welcome, Marisa. We're happy to have you with us today.
Thank you so much for having me, and I'm very excited to be able to talk more about the autoimmunity screening for kids, or ASK study. Would now be an okay time to share my slides?
Sure. Marissa's going to give you an overview of the ASK study, and then we're going to come back, open it up to some of the questions that were sent to us in advance of this afternoon's town hall, and then we'll maybe have a chance to take some live audience ones as well. So take it away, Marisa.
Thank you so much. And as Amy said, I'm going to discuss the Autoimmunity Screening for Kids, or ASK study, which is a mass screening study for both celiac disease and type 1 diabetes here in Colorado and beyond. I'll give you more information on that. Here are my disclosures, none of which are related to the data that I will be sharing with you all this afternoon. So first, a little bit more on the Autoimmunity Screening for Kids study, or ASK study. This has been up and running since 2016. It's a mass screening study, as I was saying, for both celiac disease and type 1 diabetes. And we screen children, all comers, ages 1 to 17 years old. And for the celiac disease screening portion of this study, we screen with the tissue transglutaminase IgA, which is the most common screening test to send for celiac disease. We started out really just at pediatrician offices and our children's hospital and satellite locations, but we've expanded quite a bit over the past couple years, and we're now offering at-home kits for individuals outside of the state of Colorado who are interested in getting screened. And these at-home kits are actually both finger poke kits and tubes that you can bring to the local lab or a local hospital and then get shipped to Colorado, where we run the screening. And anyone who's interested in our remote screening options should check out askhealth.org. There's more information on how to get screened if that's something you're interested in doing. I'm going to focus on the study design here in Colorado for people that come in person for a screening visit. And so at their initial screen, we do the blood draw. We get some basic demographic information and information on family history of celiac disease and type 1 diabetes. We ask about whether children are already on a gluten-free diet. We ask about some basic GI symptoms. And then, as I was saying, we also do that blood draw. For children that screen positive, we ask them to come back in 4 to 6 weeks to repeat that blood draw. And then we give them a more extended symptom questionnaire. And really, we're looking at two main outcomes for celiac disease. The first is persistent antibody positivity, or something you all may have heard referred to as celiac disease autoimmunity. And that's when you have 2 positive tests on at least 2 consecutive samples. And then the other outcome that we're monitoring for is celiac disease. And so getting a diagnosis of celiac disease takes more of a workup than just meeting this outcome of celiac disease autoimmunity. And so when we're talking about celiac disease with respect to this study, we're really talking about children who meet either biopsy criteria for celiac disease or have gotten a diagnosis from a gastroenterologist based on European serologic criteria. And the ASK study has already screened actually over 32,000 children as of April. And we're aiming for at least 50,000. So we'll be going for several more years to meet our goal, but it's pretty incredible that we've already screened over 32,000. And we've actually already published the results from the first 10,000 children screened, and we were able to learn a couple of things even early on from our endeavors in mass screening. So from the first 10,000 children screened through the Autoimmunity Screening for Kids study, we found that 2.4% of children had undiagnosed celiac disease autoimmunity. And once again, meaning that they screened positive both at their initial visit and at their confirmation visit. And of those who screened positive, actually only 10% had a family history of celiac disease, and only 30% of those children endorsed any gastrointestinal symptoms. So what we concluded from the first 10,000 children screened was that really there's a very high prevalence of undiagnosed celiac disease autoimmunity here in Colorado, and that most of these children would not have been identified by our current screening practices. So we have some data on follow-up of these children who screened positive, and particularly the next couple of slides, I'm going to review data from children that were seen at the Colorado Center for Celiac Disease and diagnosed with celiac disease either based on biopsy or based on the serologic criteria that I was referring to. And we're really, really thankful for Beyond Celiac for providing the funding to us for the follow-up of these children. And so this data specifically focuses on 42 children that were diagnosed with celiac disease at our center and were identified through the ASK study. And when I say follow-up, the design of our follow-up is that we see children at their diagnosis and we ask about symptoms and quality of life, anxiety, depression, and get all of the typical monitoring labs that we would get. And then we repeat the same things 12 months later after they've been on treatment with a gluten-free diet for a year. And so this slide here is showing what happened with the symptom scores from their baseline diagnosis visit to their 12-month follow-up visit on a gluten-free diet. And with this particular plot, points to the right of the dashed line indicate an improvement in symptoms. And so what you can see is that all 42 children experienced, some improvement in both their symptom severity and symptom frequency. And then this plot here just breaks it down into all the individual symptoms that we're asking about. And so the slide that I showed you earlier referred to the fact that only a third of these children had really any of the classic GI symptoms at their initial screening visit. But in our follow-up visits, we ask about a much more extended list of symptoms that you can see here, both gastrointestinal and extraintestinal. And what you can see from this plot is that once again, overall symptom frequency improved, but there were some symptoms that really stand out more in terms of the degree of improvement. And some of those things like headaches and decreased energy are not necessarily things that pediatricians are asking about very commonly when they're thinking about celiac disease screening and who to screen and who not to screen. A little bit more on the symptom data that we were able to get from the ASK study and then also our follow-up. At their initial ASK screen, actually 29 out of 42 of these children denied any gastrointestinal symptoms. At their first baseline GI visit with us, 27 out of 29 of those children actually had one or more symptoms, which is pretty remarkable. And then following up these children after treatment with a gluten-free diet, actually 33 out of 38 children who reported any symptoms reported improvement in one or more of those symptoms. So what we can say from our symptom data is that overall children who were screened for celiac disease through mass screening, diagnosed and treated, improved with respect to symptoms, which I think is a pretty remarkable thing. And this just shows a little bit more on our individual symptom data. And so this is comparing symptom frequency at their baseline visit and then at their 12-month follow-up after they had been on a gluten-free diet. And what I want to point everyone to is the blue bars here, because that indicates that they're not having that symptom at all. And so what you can see, just kind of eyeballing all the individual symptoms, in general, the proportion of children that have blue are going up from that baseline to that follow-up visit, indicating improvement. And this is the same schematic here, but just showing symptom severity. And what you can see is, once again, moving from the baseline visit to the follow-up visit on a gluten-free diet, the proportion of children who are not having that symptom at all, and it's not severe at all, is going up. So what about labs? Well, actually, for most children that were diagnosed through the ASK study, most of their baseline labs were normal. We did have quite a few children who had iron deficiency at the baseline visit, and that's indicated by this plot here with ferritin. That's how we monitor for iron deficiency. And at our center, we consider anything below 30 to be iron deficient. And so what you can see looking at that plot, and sorry, we'll go back so that you can actually see that, but what you can see looking at the plot is that there were quite a few children below that level of 30 at their baseline visit. And overall, that number was improving from their baseline visit to their follow-up visit. So the main take home from this slide is that iron deficiency was very common for these children, and that overall it improved with a gluten-free diet. So what about quality of life? So what we found, similar to symptoms, and this plot is very similar to what I was showing you earlier with our symptom data, anything to the right of the dashed line on this plot indicates an improvement in quality of life. And overall, when you look at the mean quality of life scores, quality of life did improve after treatment with a gluten-free diet. I think one thing that's really interesting about this data is that you can see there are some differences here based on whether we were asking the child about their quality of life, which is indicated by the self-report, or whether we were asking the parent about the child's quality of life, which is indicated by the caregiver report. And there were some differences based on the different domains of quality of life. And what is not shown on this slide is that there were some differences in improvement based on the age range of the child. So I think another really important point that comes up about mass screening and potentially identifying children who are less symptomatic is, are we really going to see the same benefit? And not only are we going to see the same benefit with respect to symptoms and labs and the data that I was showing you, but are we actually going to make them worse by making them go gluten-free? And so what we have found in our study following these 42 children is that that was just not the case. There really was not an indication of increased depression based on both the parent and the child report. And there was also not an indication of increased anxiety on the gluten-free diet based on both the child and the caregiver report. So that's what we found in the autoimmunity screening for kids study. So what is the current state of screening kind of more broadly throughout the US right now? Well, the US Preventive Services Task Force currently states that there isn't really enough evidence to support general population screening for celiac disease. And this is based on the data that's available on the risks and benefits of screening in asymptomatic individuals. And the AGA actually just released their guidelines that kind of echoed this sentiment about mass screening. I think a big problem with this, and I alluded to this earlier, is that most children, when they present with celiac disease, actually do not present with the classic gastrointestinal symptoms. So I really like this pyramid because it kind of lays out the prevalence of celiac disease based on these different parameters. And so if you screen just based on classic gastrointestinal symptoms, you're really going to miss most of this pyramid, and you're only going to get the very tip of the pyramid. If you start adding in other things like extraintestinal symptoms, other diseases that put you at risk of celiac disease, you're capturing more, but you're still not capturing everyone. And really, the only way to identify everyone with celiac disease is an approach like mass screening. So who is considered at risk of celiac disease, and what are some of the other recommendations with respect to screening asymptomatic individuals? So everyone, all of the different organizations are in agreement that children who present with symptoms should be screened for celiac disease and are considered at risk. The North American Pediatric Society for Gastroenterology, Hepatology, and Nutrition, and the European Society both support screening asymptomatic children who are in the following at-risk groups. So children who have a family member, a first-degree relative with celiac disease, are considered at risk. Children with other autoimmune diseases like type 1 diabetes, autoimmune thyroiditis, autoimmune liver disease, juvenile chronic arthritis are considered at risk. And then children with certain genetic syndromes and immunodeficiencies, so things like selective IgA deficiency, Down syndrome, Turner syndrome, and Williams syndrome. And I think these are a very interesting group of children because we don't understand exactly why they're at increased risk, but they are at increased risk of celiac disease. And I think another, kind of fallacy of these guidelines with respect to screening of asymptomatic individuals is that they make a clear differentiation of who should be screened based on symptoms. But we've seen time and time again, including in the ASK study, that symptoms really are just not that useful as a way to determine who should be screened, because symptoms aren't predictive of who's going to screen positive for celiac disease. And oftentimes in screening studies, when you ask people about symptoms, you realize that at least 2/3 of individuals are not truly asymptomatic. So it's really difficult to base policy on symptoms when we're seeing consistently that they're not really a good way of classifying individuals. And then I think another issue with these guidelines is that, they say we really don't know the potential benefits and risks of identifying asymptomatic individuals. But what we've seen in screening studies is that it certainly, screening studies seem to suggest that there are potential health complications of celiac disease identified through screening. And this slide lists 5 different screening studies that have looked at health complications associated with screening identified celiac disease, and have found that individuals with screening identified celiac disease may have lower mean height, lower mean weight, lower mean BMI, and also may have lower bone mineral density. So I think all these studies that I've kind of alluded to and reviewed with you all suggest that there really may be complications of screening identified celiac disease, particularly with respect to unrecognized symptoms, nutrition, and bone health. So what is next? How do we, really decide whether celiac disease mass screening is a good or a bad thing? And I think there is already a lot of evidence that points to the fact that screening and early detection are beneficial, particularly when we think about those potential complications of diagnostic delay, when we think about the fact that symptoms are not predictive. And if we continue to screen based on symptoms, we're really going to miss a lot of people. And then I think based on the data that I showed you from our follow-up, we have seen that children with screening identified celiac disease, when you treat them, you do see an improvement in symptoms and quality of life. But I think there are still a lot of questions that remain with respect to screening. The question of complications, particularly in asymptomatic celiac disease, comes up. And I think, if this is the standard that we're held to, it's going to be really, really hard to study that, because most people, once they know they have celiac disease, they want to be treated. They don't want to go decades of their life without treatment just to see what happens. So I think that's a really hard question to ask. I think there is question about the cost effectiveness of screening, and, how for policy changes, insurance really wants to hear that, there's a cost benefit to screening. And we're hopeful that some of the data that we're getting from the ASK study is going to help address that in the next phases. And then I think also, how effective is mass screening in comparison to the screening strategies that are supported by NASPGHAN and SPGHAN, particularly, more targeted screening of high-risk groups. And so with that, I just want to thank everyone on my research team at the Colorado Center for Celiac Disease, everyone on the ASK study team, all of our research participants, and we were talking about this earlier before the town hall started, but I had my own daughter screened through the ASK study. So if anyone has questions about the logistics of that and how easy it is to get screened, I'm also happy to discuss that. And then, of course, to all of our funders, including Beyond Celiac, without whom this work would not be possible.
I was muted. Thank you. I think that your overview on this was so easy to follow, and I think so informative for all of our participants who have tuned in. And there's so many things I could ask you about, but a few thoughts that came to my mind. It used to be at one point in time that there was a really very specific look that celiac disease had in children. And they were definitely considered to be symptomatic. They were, often would present with pretty noticeable weight loss, a huge distended belly. My daughter was diagnosed in those days. And, what the classic look of celiac disease, which was, I think, celiac disease crisis at that time, the children almost looked like children who were starving. They looked like they had malnutrition. So the first part of my question is, has there been a change in the way that overall children who have celiac disease do present, especially taking into account that there's a large group of them that are asymptomatic? Is that making sense to you?
Yes, no, that's a perfect question. And I think, the presentation of celiac disease is changing for many reasons. So we still do see children who present with those classic symptoms who are in more of a what we call celiac crisis. And, there are still some children who have to come into the hospital, unfortunately, when they're diagnosed. But that is by and far the minority of children that we are seeing. And there was actually a publication from New York that I think is about 10 years old now, but that looked at the presentation of celiac disease in the pediatric population, and showed that really a majority of children now are presenting with these non-classic symptoms. So things like headaches, joint aches, iron deficiency. And so the face of celiac disease, so to speak, really, I think, is changing within the pediatric population. I think that also brings up the point of that can be somewhat problematic when we're thinking about celiac disease screening in the primary care setting, because a lot of what we learned in medical school, Amy, is exactly what you were describing with respect to how children should present with celiac disease. So in all the medical textbooks, it's, children with very big bloated bellies who have lost a lot of weight. And it almost makes it seem like when a child presents with signs of celiac disease, it is going to be incredibly obvious. And that's really just not how the majority of children are presenting anymore.
Right. So I guess what that says to me in a way is that screening becomes even more important. If the way that a doctor is going to look for celiac disease or has been taught to look for celiac disease isn't going to line up with the way you find people with celiac disease, then screening becomes an even more important tool for finding the more children who have it. One of the things too that you brought up that I thought was interesting is I think there has been some discussion of this. How do you balance diagnosing a child who is or who thinks they are asymptomatic and balance that, in their world, they're thinking they're leading a normal, healthy childhood. They're having a normal, healthy childhood. You find them and you diagnose them and they go on the gluten-free diet. And what is the balance of the benefit they got out of that versus the complications of being on the gluten-free diet, the social implications and all that. So it seems to me what your study is saying is we looked at those things and we didn't find that if you want to look at what that balance is, that being diagnosed and being on the gluten-free diet outweighs the downsides of it outweigh the benefit side of it. That seems to me to be what your study is saying. It's particularly in what you're talking about with anxiety and depression.
Yeah, I think that's a really, really good summary and high level overview kind of the results. For the children that we were following, there was not an increase in things like anxiety and depression from being on a gluten-free diet. With that said, that's the data, and anecdotally, my clinical experiences in, treating and diagnosing children who are asymptomatic with celiac disease, it can be really hard in the beginning, right? Everyone knows that going on a gluten-free diet is hard, and particularly as a child, and if you're not having symptoms, like there's a lot that goes with that. I think it's hard when you're not having symptoms. It's hard when you are having symptoms. And so one thing that I think is really important about the care that we provide at our center is having a psychologist involved to help with that adjustment. I think that's an important part for all, chronic diseases, but particularly for celiac disease, where you're having to make a pretty drastic change to your diet.
Yeah, and I think that would be a newer aspect of follow-up care. And one of the questions that we had submitted to us in advance was, what does follow-up care look like for a young child who's just been diagnosed with celiac disease?
Yeah, and so I will give you the caveat that I'm speaking to the care that we provide at our center, and it can definitely vary a little bit region to region. But typically what we recommend is at the time of diagnosis, we have a wonderful dietitian who provides group education classes. And so we have all of our newly diagnosed patients and families, and I say families because the family is also a very important part of this. We have everybody join for that group education class where our dietitian kind of reviews the basics of being on a gluten-free diet. And then we give our patients 3 months to learn those things and to really go out and try them, to try to go out to eat, to try to prepare foods at home. And then we follow up with them in clinic in 3 months and we repeat labs, specifically antibody levels, and then any other labs that were abnormal at the time we diagnosed the child. So things like iron and vitamin D, if they were deficient, we'll repeat that at the 3-month visit. And we have them meet with the doctor and then also our dietitian and our psychologist. And the appointment with our dietitian and our psychologist is a little bit longer because they are really taking a full dive with that child and their family into how things are going on the gluten-free diet. And then if things are going really well at that 3-month visit, we space out follow-up and repeat annual labs to every year. For most children, we are expecting that antibody level is going to normalize within 2 years. And then the other things that we're monitoring for are things like iron deficiency, vitamin D deficiency, and the development of other autoimmune diseases.
Mm-hmm. I thought that also in the study, the data that you were collecting on how common iron deficiency was in children was so interesting because that's a measurable downside to not being diagnosed. And so to me, that spoke pretty loudly about the benefit of screening children.
Yeah, and what we didn't collect or tease out with that data that, I think moving forward, I really would like to take a deeper dive into is that I think a lot of these children just get better with the gluten-free diet alone, like not even having to take extra iron, just going gluten-free and having better absorption impacts their iron pretty drastically.
Mm-hmm, mm-hmm. Someone who had submitted a question in advance wanted to know how often are you finding children who screen positive for both celiac disease and type 1 diabetes?
Yeah, so I will say that, within the ASK study, I don't think we have had any children yet who screen positive for celiac disease first and then develop diabetes. It's usually the other way around. And give me 1 second. Sorry, the lighting in my office was automatically dimming. We haven't found anyone who has had celiac disease first and then diabetes. There hasn't yet been anyone to screen positive yet for both islet autoantibodies and TTG at the same time. But there have been multiple children that have been picked up to have islet autoimmunity, which is the precursor to type 1 diabetes, and have been followed over time and have developed celiac disease. Mm-hmm, mm-hmm. So it seems like for many children, diabetes precedes celiac and not usually the other way around.
Right. Someone else had a question that they submitted, said that I have celiac disease and have 2 daughters, age 3 and 5. I've asked their pediatrician about screening, but I've gotten pushback due to their lack of symptoms. What is an appropriate age to have them screened? And should I push to have that done?
So our NASPGHAN and SPGHAN guidelines say to start screening family members at age 3. So I would say now is an appropriate time to have your children screened. And if you would like to get them screened through the ASK study, it's a really easy way to get it done too. But I would push their pediatrician to have that done.
Right, right. You had mentioned that in the ASK study, children are considered to have celiac disease in one of two ways. And that would be if they have the TTG screening twice, which would indicate celiac disease autoimmunity, and then they follow up with either an endoscopy and biopsy, or if they meet the SFGAN requirements for celiac disease. So SFGAN is a European way of diagnosing celiac disease in children. And can you tell our audience a little bit more about what those requirements are and why those are acceptable in the ASK study?
Yeah, so the SBGAN criteria are a specific set of criteria for diagnosing celiac disease based on labs. And what it entails is having a really, really high TTG, so over 10 times the upper limit of normal. And then on a separate blood draw, having an additional celiac disease antibody, something called an EMA. IgA, and that's a more specific test than the TTG. And, it's not, I will say in my clinical practice, it's not my first line in what I go to, because here in North America, the biopsy is still the gold standard. There was a important period of time during this study, however, where, it was during COVID and we weren't doing elective procedures. Mm-hmm. And so there was a period of time here in North America where we were applying this criteria much more regularly just because of the times. And I will say, even now in my clinical practice, there is certain instances where if, for instance, a child meets that criteria and they're already gluten-free and clinically they are feeling a lot better. There are times where I apply that criteria because the family just doesn't want to do a gluten challenge to go on to diagnosis. So I would say it's not, our most common way of diagnosing celiac disease, but there are certain clinical scenarios that we apply that here in North America. And because of that, we felt that, particularly given the time that we were recruiting during this study, that it was important to include that as diagnostic criteria.
Yeah, that totally makes sense. Someone else asked if a child's parent has celiac disease, but tests negative in the ASK screening. I don't know if this actually happened, but this was the question. Can we assume the child is at very low risk and likely won't need to be evaluated again? I guess basically the question is, if you turn out to get a negative screening in ASK, is that the end of the story, or do you need to get reevaluated at some point in the future?
Yeah, so I think that's a really good question about screening more broadly. I think, you can develop celiac disease as an adult for sure, but what we have seen in prospective studies that follow children at genetic risk of celiac disease over time, what we have found is that the highest risk period for developing celiac disease really seems to be the first 10 years of life. And so what we recommend with respect to screening frequency at our center is every year until kids are 10, and then after that, spacing it out to every 5 years. So one negative TTG test definitely does not rule out celiac disease for life. But I think if you're an adult and you're getting a negative test, that is a different scenario than a younger child getting a negative test and the risk of developing it later.
And that would also be coupled with lack of symptoms, although lack of symptoms is tricky to talk about. But let's say you had a negative test and then you became symptomatic in some way, whether it's gastrointestinal or something else, that would speed up that 5-year repeat evaluation, I would assume.
Absolutely. So when I'm talking about screening frequency, I'm talking about screening frequency in asymptomatic individuals. If you're developing symptoms of celiac disease, you should definitely talk to your doctor about getting screened. No need to wait 5 years.
Right, right. Someone said, I love the fact that there's a free health screening with celiac testing that's available for children. At some point, Would you include adults? And you've already talked about this in your presentation, but we can go back over it again, and even going beyond Colorado or outside the boundaries of Colorado.
Yeah, so Ask has actually done both things. There was a period of time where Ask was screening parents for celiac disease as well, so was screening adults. And we're already, offering at-home kits for people who want to get screened outside of Colorado. I think, screening the adult population would also be really interesting, and something that, I hope it's expanded more broadly someday.
Right. So we do have people who are tuning in, who are shooting questions to our people behind the scenes. And so I'm going to switch over to them for a moment and ask whether we have any questions from our live audience that you want to put forward to Marisa.
Sure, yeah, jumping in. We have a couple questions about what about a grandparent, and this actually applies to my own children, and but someone else is asking that. My husband's mother and his brother have celiac disease. My husband does not have celiac disease. What are the risks for my children? It's not, they always say the parent or sibling, but what about a grandparent and an uncle? How likely is it that that risk would be passed down and kind of like skip over?
Yeah, so excellent question. Based on the literature, I don't have exact numbers that I can give you for risk, and I can tell you that the current screening guidelines, as you alluded to, are really for first degree relatives. With that said, we see a lot of children in our clinic who, don't have a first degree relative, but have a grandparent. And that's why I think, screening more broadly is a really important thing. So I would say, just because dad doesn't have it doesn't mean that they are out of the woods, and getting them tested is still a good idea.
Thank you. Yeah, and someone else asked about what are the specific tests in the screening kit for, what are you testing for, what specific antibodies?
Yeah, so for celiac disease, it's just the TTG IgA. So I'm really glad that you brought that up, because the Ask study actually does not screen IgA levels. And so presumably, if someone were IgA deficient, this study could miss them, meaning that the TTG IgA would come back negative, but they still have celiac disease. So I think it's another important thing to just emphasize that this is a research study. And so if your child is having symptoms or struggling with anything, it's really important that they see their physician for that as well, because it may not, for instance, be related to celiac disease, or it could be a scenario of they have IgA deficiency and they really do need more testing for celiac. So that's the celiac portion of things. And then the diabetes side of things, we test for multiple islet autoantibodies, which have been shown to be over 70% predictive if you have multiple positive islet autoantibodies, over 70% predictive for progression to diabetes within the first decade of life.
Thank you. Someone else was asking about potential, if you know anything about perhaps the research into this, potential less invasive ways to diagnose celiac disease, especially in children. Not everyone wants to have their child undergo an endoscopy. And if you've heard anything about potential less invasive tests or other ways to screen and detect.
Yeah, I think there's a lot of very interesting things on the horizon. So first of all, the European criteria for the serologic diagnosis, a big part of why we are not routinely applying it here in North America is that we just haven't looked at that data with our North American labs. So there's studies underway right now to look at whether that criteria can also be applied here in North America. So it may be someday that the same criteria I was talking about earlier from Europe is something that we are more routinely using here in the States. So I think that's one thing. The other thing that's very cool on the horizon is something called transnasal endoscopy. They use it routinely for other GI diseases that we see in kids, like eosinophilic esophagitis. And so there are studies underway now to see if we can get adequate intestinal biopsies from a transnasal scope. And this is an endoscopy where they give kids virtual goggles and they're just hanging out watching a movie. And while they're doing that, we go in through their nose. So it's no general anesthesia, and we would be able to get biopsies essentially while they're awake. It's a clinic visit. So you check in, check out, and then they can go and eat something shortly after that. So that would definitely be a less invasive way. And then I think the other very cool thing on the horizon is something called IL-2. And that's kind of a blood marker response of the immune response to gluten in people with celiac disease. And so right now, the way that this is potentially being used is having people do a single dose gluten challenge and then measuring whether they've had an IL-2 response after having that single dose of gluten. And so this potentially would be a really great, less invasive way to diagnose celiac disease, but also could have a very important role for people who are already on a gluten-free diet and feeling better.
Those are all really exciting. I hadn't actually heard about the transnasal endoscopy, so I'm sure people would be really interested in that in the future if it works out for celiac. Someone asked that, or said that they went to the Ask website to look at the screening kit, and it looks like you have to be a parent before you can be screened as an adult. Is that correct, or can any adult?
That's correct. Sorry if I wasn't clear on that before, but you have to be a parent of a child in the study. So they screen adults that way, but you have to be a parent.
Thanks, Maria, for bringing in some of our live questions. I'd like to talk a little bit more about the study that you did through the Beyond Celiac SSCD grant, and maybe a little bit about the way that the conclusion by the Preventive Services Task Force influenced your decision to look into this. My understanding about it is that, or of it a little bit, is that they're saying there's no evidence. And so what we need to do is to create the evidence before this will move up in the preventative services evaluation of how necessary it is. So can you talk a little bit more about that aspect of what you're doing and why it's important to, in a sense, influence or give the evidence that task force is looking for? Yeah,
so I think to your point of how much of what we constructed was due to the USPSTF statement, I would say 100%. It was a response to that because we felt like, at least from our experience with screening studies in Colorado, that screening and early detection is a good thing, but, based on their review of the evidence, there's clearly insufficient evidence right now. And a big part of that is, what is the outcome of celiac disease screening? What are the longer term outcomes? And then what are the risks and benefits of screening individuals who they say asymptomatic? I'm going to say who would not be picked up due to symptoms in, the primary care setting. Because as you saw from our data, a lot of them actually do have symptoms. And so it was completely constructed as a response to the USPSTF. I think in terms of next steps, so we are one study, and whether that, completely changes the USPSTF, I think, we have a ways to go. We need to look at cost effectiveness, like I was saying, and we need to look at how this compares to our current screening strategies. And we probably need studies outside of Colorado that also show that this is a cost effective and beneficial thing before the USPSTF would change policy more broadly. With that said, I will say insufficient evidence does not mean that this is something that shouldn't be done. It just means that there's not enough published evidence to do it yet. And so there are other disease processes where they moved up with screening, even outside of the USPSTF. So I think there are opportunities for advocacy even before, the level of evidence meets really the more strict criteria of the USPSTF, particularly within organizations like the AAP.
Mm-hmm. I think one of the things that you mentioned was that we need a cost benefit analysis in order to be convincing. And so what does that, in a sense, what does that entail?
Yeah, so
I think you also said it's something you're planning to do, so I'm interested.
some of that is actually already underway. We're very fortunate to have a fellow who's very interested in cost effectiveness research. And so she's already started doing some of that work. And so what that entails is looking at, how much it actually costs to screen over 32,000 children for celiac disease. And then looking at the children that we are able to diagnose with celiac disease, how does that affect their quality of life? And there's very specific measures, things like quality adjusted life years, that because we are collecting data on quality of life, we'll be able to calculate. So that really is the next step.
And we've talked a bit about how people from outside of Colorado, parents of children, since we've become specific about it, can participate. How important do you think that outside of Colorado data is?
So I think every person screened helps and adds to the data. I think, unfortunately, when we're talking about the follow-up data on outcomes, we're not getting that same data, for people that screen remotely. So I still think there is certainly a role for other screening studies too, for people that are interested in collecting that data on outcomes.
Yeah, the follow-up care that you described at Children's Colorado sounds pretty ideal. I don't know that most people have that access to quite that level of follow-up care. So I think, to me, when I think about screening, I automatically think about, and when I try to think about how you describe screening and the role that screening has, I think about colon cancer, because screening for colon cancer is you're asymptomatic. There's nothing special about you except perhaps the age, and that has gone down and maybe will go down even further, but you just broadly screen everyone. And I think that's, in a sense, what we're looking for in celiac disease. And so this is the question I would ask: does that help us to get to that large percentage of undiagnosed cases of celiac disease?
Yeah, so I think mass screening is the best strategy for us to get at the cases that are undiagnosed. Absolutely. But I love that you're bringing up colon cancer screening, because for colon cancer screening, there is I don't want to say easy. No one enjoys undergoing a colonoscopy and having to get something like a polypectomy, but it's relatively like an easy intervention too for many people that are, screening positive. Whereas I think part of what the USPSTF was saying is that the gluten-free diet is considered, a harder intervention. And so I really am curious to see how over the next couple of years, as more drugs become available and hopefully the gluten-free diet is no longer the only option for people with celiac disease, how that also frames the conversation around screening and the acceptability of that.
That's an interesting way of looking at it that I hadn't looked at it before. So we talk a lot about undiagnosed celiac disease and how many people are undiagnosed. And if you're looking just at the pediatric population, is there a number that's typically accepted for the number of children who are undiagnosed?
Yeah, I'm actually probably not a great person to ask this question, because here in Colorado, we do so much screening that I feel like, more kids are diagnosed than undiagnosed. But when you look at the percentages in schools and other screening studies, you get, close to a maximum of 1%. And what we're finding in, prospective birth cohort studies and studies like ASK is a number closer to 2 to 3%. So that means that over half of children easily who have celiac disease are undiagnosed.
I think the number that we often hear, I don't know, in adults, it's so hard to pin that number down. We keep trying, but we know it's not 100%. So let's work toward that, I think, in the meantime. I'll give Maria one more chance to ask a question or two, I think is all we have time for from our live audience. Maria, if you have any that are pressing.
Sure. I just think I've seen some questions around this, and I've had my own experiences with my son, as I was mentioning. But Marisa, if you have any suggestions or tips, how can you be a good advocate for your child at the pediatrician, especially if they seem resistant to testing or don't know much about celiac disease?
Yeah, so I think, it's a problem more broadly with respect to like the available education. And that's something that our center is very interested in, developing more resources specifically for providers. But I think, some of it sometimes comes from not even knowing, like, what do I order for celiac disease screening? So I think, in terms of advocating for having your child screened, going to your pediatrician and saying, I want you to get a TTG IgA and a total IgA level can also really help, because then they know exactly what you're wanting.
Okay, well, I think we're getting close to the hour, and I do want to have some time to thank Marisa. I think we've learned a lot, some things we've never heard of before that you've introduced us to and thinking about, and also to say thank you for being such a good steward of the research funding that Beyond Celiac provided. It's nice to see, and I think for our community to see that when we fund research, it has it leads to things, and the reason that research is done is because it has a specific goal in mind, and that we keep working bit by bit toward the goals of more diagnosis, better methods of diagnosis, better numbers in diagnosis, and ultimately better treatments and a cure. So thank you for spending this time with us. You've been terrific as always. I think Marisa has a really good way of explaining things. So we're happy to have her join us and look forward to maybe she'll come back again sometime in the future.
I would love to. And thank you so much for having me. And thank you again to Beyond Celiac more broadly for funding this research, because once again, it would not have been possible without that.
Right. And Marisa is taking this research to the point where it will be turned into a publication. And when that happens, we'll report on all the details on it. She also, through one of the people that she works with at Children's Colorado, presented some of this preliminary data at DDW, which is important because a presentation at DDW gets the information out in front of a group of clinicians and researchers, so they know what you're doing, and that helps to spread the word too. So those are all good things. And we thank everyone who joined us and for all of your great questions, and people on the back end. Maria, thanks for answering questions. Bailey and Kate, thank you. I don't know, they answer questions behind the scenes too that we never see, Marisa. So
Yeah.
thanks to everyone who is doing that.
And to that point, if there were questions that came up that went unanswered, I'm happy if you guys email those to me to send you a response.
Okay, thanks a lot. All right, thanks everyone. Enjoy the rest of your afternoon.